Welcome, everyone. I'm Donna McKay, the Executive Director of Physicians for Human Rights, PHR. Since launching last March, PHR's webinar series on the health and human rights implications of the COVID-19 pandemic has provided a forum for healthcare workers, scientists, and researchers, advocates, and voices from the front lines to examine and speak to the various impacts of the pandemic on public health systems, on healthcare workers, at-risk populations in the US and across the globe. So I really want to thank you for joining us today. This is our 35th conversation in this discussion series. And today our expert panel will discuss the pandemic's abiding impact on mental health, which has grown more severe by the day, including, understandably, increased rates of anxiety and depression, intense burnout among healthcare professionals, and of course, it affects their families as well. The Kaiser Family Foundation reported that 4 in 10 adults in the US have reported symptoms of anxiety or depression disorder in January of 2021, which is a 400% increase among adults who reported these symptoms in January 2019. So we have over 400 people live with us today to listen to experts in mental health and child psychiatry and healthcare professionals from the front lines share their insights and their experiences of how this pandemic has introduced chronic stressors and anxiety among healthcare workers, our children, and our general population, and how critical it is to expand access to mental health services. I'm really thrilled to welcome back today's moderator, Dr. Gail Saltz, whom PHR is lucky to have as a board member. Gail is a clinical associate professor of psychiatry at Weill-Cornell Medical College and a psychoanalyst with the New York Psychoanalytic Institute. Gail was among one of our first guests in early April 2020 when we first discussed the mental health implications of the pandemic, and has just been an extraordinary resource in guiding PHR's response. So Gail, I turn it over to you and thank you all to the panelists.
Thank you, Donna, and thank you all for being here for this hour. And I'm really thrilled to be back and bringing you what I think is some really important information today. As we approach 1 full year of managing the COVID-19 pandemic, certain vulnerable groups have been especially traumatized by the numerous extreme stressors brought on by the pandemic. Overworked and overburdened, facing repetitive trauma, loss of school, loss of structure, loss of feeling safe, economic stability, and the impact of systemic racism. These at-risk communities have extreme stressors, really too numerous to list. As a mental health professional, I am increasingly aware of the impact on children, college-age kids, the entire health professional community, including mental health professionals like myself, and particularly those on the most front lines, like nurses. Burnout specifically is a state of emotional, physical, and mental exhaustion caused by excessive and prolonged stress. It greatly impacts the ability to function at work, and it impairs one's ability to function in their personal life as well. In addition to burnout, large groups of at-risk communities are struggling with various mental health symptoms. Rates of major depression have gone up, according to the CDC, 31% this year across all age groups. Recent surveys have found that 80% of mental health professionals report burnout and 16% are reporting depression. A Mental Health America survey of 1,119 frontline workers found that 76% reported burnout, 75% reported feeling overwhelmed, and 86% reported anxiety. Today, we have 3 amazing panelists with us to elucidate the traumatic impact that COVID-19 has had on these vulnerable groups, and to think about ways to approach helping them. The first panelist is Felton Earls. He is the Emeritus Professor of Human Behavior and Development at the Harvard T.H. Chang School of Public Health. He is Emeritus Professor of Social Medicine at Harvard Medical School and former Blanche F. Edelson Professor of Child Psychiatry and Director of the Division of Child Psychiatry at Washington University School of Medicine in St. Louis. Next, we have Jessica Gold, who is an assistant professor and director of wellness engagement and outreach at the Department of Psychiatry at the Washington University School of Medicine in St. Louis. And last, we have Matthew Howard, a director of scholarship and leadership resources at Sigma Theta Tau International Honor Society of Nursing, a part-time staff nurse in the emergency department at Eskenazi Health in Indianapolis, and nursing faculty in the graduate and doctoral programs at Northern Kentucky University. Thank you all for being with us today. And the first question is going to go to Tony. Your decades of work in the psychiatry space has focused on psychological development of and environmental impacts on children. The pandemic has upended the daily schedules, the education, and social lives of countless children, including their home life, where parents and guardians are either working from home throughout the day or away at a job while kids are at home. Can you speak to us about the impacts of these stressors on the mental health of children?
Thank you very much, Gail. It's a pleasure to be back at PHR and in a discussion like this that's so important to our contemporary lives. The issue that consumes me, has come to consume me, is to hear directly from children about their mental health and about their caregiving arrangement and about their educational progress, given the impacts of the pandemic on school closing and opening, parents working, and healthcare services that are required because of the increased burden of depression, anxiety, and traumatic experiences. In all of this, what I worry about, however, is losing focus on the child's voice. There's not one example I can think of, with the exception of UNICEF, where children's voices in this pandemic have been elucidated and systematically recorded and documented. So the critical problem to me, dealing with children and families, is how to bring the children's voices and their activities, their interests, their burdens, their successes, their level of competence into the discussion about things like school closing, or vaccine, being vaccinated, understanding the health risk associated with pandemic.
Thank you. Jesse, many of us have seen countless articles on healthcare worker burnout, the toll the pandemic has taken on the mental health of healthcare professionals, from frontline workers to hospital administrative staff. And as a mental health care professional yourself, can you speak to the impact the pandemic has had on healthcare professionals, and in particular, psychiatrists and psychologists who've been working to maintain the mental health of healthcare workers as well as the general public in what has become a pandemic of mental health issues?
Yeah, thank you so much for asking the question. You know, what Tony mentioned about people not speaking up for themselves and having a voice in the conversation, I think is really important for healthcare workers too. We tend to not want to talk about emotions, so we don't get ourselves involved in the conversation about feelings. We're much more likely to advocate for patients than to advocate for ourselves, and are in the conversation very regularly on the front line saying, we need this for our patients, we need this to fix the solution, we need this for the pandemic. But very rarely do we say, what has this been doing to us? And what has this been like for us? And what has it been like? It's been quite challenging. It's been over a year of constant trauma. It's been over a year of not sleeping. It's been a year of maybe getting sick and bringing that home to our families, or bringing that home to ourselves, right? It's been a lot of really new challenges for people that could risk our lives, could risk our families' lives, and is just really a different work environment for many people that has higher rates of death than they've seen before, and has really changed the whole game for healthcare workers emotionally, to be completely honest. And so, you know, people are struggling with the same things too that the general population is struggling with, because healthcare workers also are people. So they're also dealing with school closings and job loss in their partners, and, you know, having to teach their kids while they're also doing work from home, and everything you could possibly think of. So I think when you look at what are healthcare workers dealing with, they're dealing with anxiety, burnout, depression, sleep, trauma, all of it. And then what are mental health care workers doing? Listening to all of it, right? And consistently. And as a mental health care worker who often doesn't consider myself in the conversation, I think mental health care workers tend to think we're not frontline workers. And so we just listen, and we're there to support. And our role is to be a listener, a supporter, a person who's there to witness and bear witness, and to be there as much as we can. And we do that regularly without thinking about that being something that can burn us out. And boy, is it doing that right now. And I think Right now, we're just getting to the place that we're starting to recognize it and name it and say like, oh, wait, we're part of this conversation too. And actually saying that on social media and saying that in articles and asking for vacation and putting boundaries on how many patients we can take, even though the system is broken. And if we don't take patients, that means they don't get care. And that means there's a wait list. That means that the fact that people need more care right now and we are saying we can't do it, that means that people will really be hurting. And that feels like we're the person doing it, but we're not. It's a broken system.
Thank you. Yeah, it's been a real good news, bad news. I think stigma has come down enough that more people are reaching out for mental health care than ever before. Bad news, there are no more of us. And so we're more than filled. I know this amongst myself and my colleagues, there's no more room. And so we can't offer more appointments. Matthew, as a frontline nurse, you've seen the unspeakable toll of this pandemic on COVID-19 patients and healthcare workers firsthand. Can you take us through a typical day in your hospital during the pandemic? How long healthcare professionals are working in one shift, and the daily challenges that impact physical and mental health of frontline workers?
Yeah, thank you for having me as well, for PHR, for having us to be able to talk about this, because it is a big issue. One of the things that comes to mind for me to be able to take you through my normal day, if you will, at a facility or at the hospital, is most of us work 12-hour shifts at a facility or at a hospital. Myself working in the emergency department at a level 1 trauma center, which is one of the safety nets for our particular city and for our county. We do see patients the entire time, right? One of the biggest things in the emergency department, at least, is as we start, we're gowned, we're gloved, we're masked, and we pretty much stay that way for that entire time, right? I've been floated several places as the pandemic has progressed out of the emergency department into the ICUs and stuff like that. And that is pretty much the same regardless of where you go, whether you're a nurse in an ICU, an OR, a step down, wherever it is, or just about any other type of healthcare provider there, period. We stay gowned for the most part. We definitely are masked. We definitely have gloves on. And what that does to us from a mental standpoint, but also from a physical standpoint, is it makes it where we were busy before the pandemic, as it were, especially in the emergency department, right? But now we don't even go to the restrooms. We don't hydrate in that 12-hour time frame because you have to take everything off to be able to do that, right? So it makes it even much more from a physical standpoint that we're having to deal with, but definitely from a mental standpoint. Some of the things that Tony was talking about in terms of caring for children in that particular phase as well. Again, where I am at the safety net facility or safety net hospital, we get a lot of patients that come in for mental health issues. And our mental health care workers are working there 24/7 right along with us, right? It's our mental health techs, it's our physicians that are doing this, as well as the nurses that are doing this, and working with these guys on a constant basis. We definitely have seen an increase in taking care of mental health related issues in the emergency department specifically, because of everything that has been going on for pretty much the past year.
Thank you. Jesse, I'm going to take that one to you as well. And in addition, if you can include, we know that burnout is a syndrome conceptualized as resulting from chronic workplace stress that has not been successfully managed. And so in the vein of this same question, what can you also answer to the long-lasting impacts of chronic burnout should it go untreated?
Yeah, you know, burnout is not a mental health diagnosis. And I think we often get that confused because we kind of conflate the two. So I can't see someone and diagnose them with burnout. And so I think that that's one thing I like to put out there, because we talk about it a lot like it is a mental health diagnosis. But when we think about it, it actually can contribute to somebody getting a mental health diagnosis. So I think that's something to put out there. So what does burnout do? It can lead to increased depression, increased substance use, increased rates of suicidal thoughts. It can lead to car crashes into like a bigger systemic way. For doctors, it can lead to worsened patient care. It can lead to decreased patient satisfaction. It can lead to patient errors. It can lead to patients staying in the hospitals longer. For another kind of bigger systemic way, it can lead to people leaving their jobs. It can lead to higher turnover in jobs. It can lead to basically like mass exodus from something where you paid a lot of money to train all these people and keep them there. So hospitals lose a ton of money that they invest in all of these people. My favorite statistic there is like the lost productivity annually to burnout in medicine is the equivalent of 7 medical school classes worth of people. That's a lot of people. So what, a medical school class is like 150 people on average. That's 7 times 150 is a lot of people, right? So it does a lot. That's what burnout does. So we need to think of it as something we should be considering. We should have considered it long before COVID. We knew we should have considered it long before COVID. What COVID's doing is making it worse.
Thank you. Tony, in the same way that healthcare workers are being stretched to their breaking points, as we can hear, we're seeing parents, families, and children feeling increased strain and stressors due to this pandemic, especially those of at-risk populations or in communities that have been disproportionately affected by the pandemic. What are the potential long-term effects of chronic stress on children?
Well, they're very important and it can be severe. It's important that children are buffered by community resources and by family and teachers, educators. One of the things that we don't know that much about is that the focus on burnout among healthcare workers may be attributable to parents and healthcare and teachers, educators as well. And so I think that there was a very good discussion of mental health of children in the pandemic back in September that PHR conducted. And one of the conclusions of that panel still resonate with where we are with children and teachers and educators in the contemporary phase of the epidemic. And that was that resources determine availability and access to services, all kinds of human services and employment services, are greater in wealthier communities and predominantly white communities than those resources are available in Black and brown neighborhoods and schools, public schools. And the consequence of the lack of access to resources means that schools stay closed for longer periods of time. Whereas in the wealthier neighborhoods, school opening, hybrid opening techniques are used much more efficiently because they have access to it. So one of the things that we would assume long range is that those students who are attending private schools and schools that are open more than closed are having their stress buffered more than those children in neighborhoods that are dealing with racial injustice at the same time that they're dealing with pandemic. And the combined impacts of those two epidemics on children has to be considerable.
So would you say, because actually I was going to go to that in terms of the uneven impact on, as you said, Black and brown communities, not only, I mean, those communities suffering, frankly, at this point we can see, right, more COVID, more severe COVID, more economic stressors, less access to care, it seems like, both medical care and mental health care. And so what do you see as the long, the bigger long-term concerns? Is it cognitive loss because of the lack of school? Is it mental health effects, medical effects? What do you see as the bigger concern?
I think the idea is very simple. it's trust. Having the experience and the belief that the organizations around you, the schools, the healthcare centers, the businesses and government are working for you, not against you, is the most important single factor. One of the things that we are experiencing in the Black community is hesitancy around being vaccinated. That the roots of that are based on historical problems and historical events that warrant distrust in the system, for sure. But how to overcome those historically derived mistrust and feeling of detachment and uninvolvement with services and politics is something that exacerbates and prolongs and makes more serious the trauma felt and experienced.
Mm-hmm. Mm-hmm.
But I think trust is a huge issue.
And that impacts children as well.
Of course it does.
Yes. Thank you. Jesse and Matthew, I'm going to send this question to both of you, but you can each answer from your perspective. Even before COVID-19, physicians had amongst the highest suicide rates of any profession. So Jesse, can you talk to us about what you're hearing from physicians you're working with who are struggling to maintain adequate mental health during the pandemic? And then Matthew, can you speak to how this pandemic has impacted perhaps your own mental health, those of your peers who are both inside so much and also on the front lines and outside of the hospital?
Sure. I am happy to go first. So I am a psychiatrist who sees healthcare workers in clinic, and I sort of see the gamut of healthcare workers from the people who clean the hospital all the way up to the deans of the hospital. And I also see spouses and children. And by children, for me, that is 18 and up. So I'm a college student provider. There are a lot of healthcare worker college students home right now because they didn't get to do in-person learning or did hybrid. So there are a lot of people that I'm seeing now that maybe wouldn't have been my patients before. But with that being said, a lot of what people are struggling with are these things that have changed in their workplace so much, and they're seeing a lot of things that are just hard. And, you know, as healthcare workers that have never said a lot of that out loud, that just what they're seeing is hard, you know, that's the kind of thing that we talk about, that they're allowed to say that they're allowed to have feelings, that they're allowed to be struggling. And that coming to me is not something that they need to be, that it's a weakness in any sort of way. And I think that's one of the reasons why healthcare has had such a problem for so long, because we have had high depression. You're right. We have among the highest suicide rates of any profession. That approximation is 300 to 400 suicides a year in physicians. That's an approximation. It's probably low. And women, it's 2 to 3 times the general population higher. And in men, it's still higher than the general population, but not that much. And if you look at you look at kind of what's happening overall, women are having all these external additional stressors that you're seeing too. So I think you would be more concerned that that's going to be a problem over time. I think, again, Black and brown populations for physicians and in other healthcare populations make me more concerned as well. They're a population that has additional mental health hesitancy to begin with. They might be among the people who work in healthcare that are people who don't have access to full-time benefits. So they might not even be allowed to see me in clinic because they can't have access to see me in clinic. And yet they're seeing a lot of patients that look like them. And they're having a lot of COVID in their family. And they're having a lot of grief and a lot of pain, and they have nowhere to go. And yet they might not even know mental health is something they can talk about because culturally they never did. So that part makes me very concerned, and I think is not something we talk about enough. And healthcare workers of color are dying substantially more than healthcare workers that are white. And that's also something we don't talk about because we barely talk about the fact that healthcare workers died of COVID. So I think there are all of these things that are just adding up, and it makes sense that people struggle, but we really focus a lot on patients, and we should, and we do, and that's our job, but we're humans too. So I think that that's something we have to hold at the same time. And it doesn't mean we're minimizing the fact that we're providers and that we care about people, and that's like our profession, which we value, if we say, oh, by the way, I actually care about myself too.
Thank you. Matthew, what do you have to say?
Well, I have to come back to what Jesse was saying. I have to come back to my emergency medical services roots, right? So the first thing that we always teach in EMS, of course, is scene safety. You know, if you can't take care of yourself, you can't take care of your patients, right? It also brings me back to earlier in the pandemic. I did an interview with some individuals who put out a study in Worldviews on Evidence-Based Nursing. It's called a longitudinal analysis of nurse suicide in the United States. And Dr. Judy Davidson, Dr. Sidney Zazuk and their team did a great study looking specifically at this from the nursing side, because what Jesse said, there was such a large amount from the physician side. They wanted to look at it specifically from the nursing side of things, and definitely in their studies found out, of course, that nurses were at greatest or greater risk of suicide, obviously, and then the general population, even more so than some of their physician counterparts as well. And it leads me to come back to my own mental health and how we've kind of taken care of or done not so good a job of taking care of, if you will, our own mental health during this. We do focus a lot on how to care for others and how to take care of the physical needs, and oftentimes shy away from the other component, right, that mental component. In the emergency department, for me specifically and for my peers, I know definitely many of us have suffered burnout. I know and understand those symptoms of burnout. And there have been times where I've seen that in myself, and definitely see that in my colleagues, see that in my physician colleagues as well. And ways to be able to take care of that and to deal with that. We even further compound that in the pandemic period by doing the isolation that we need to do to be able to end this pandemic, of course, but that is definitely helping to harbor more issues, right? Have those feelings of isolation, those feelings of depression that we are very easy to be able to diagnose or see in other individuals, but not so much to be able to turn it back on ourselves to be able to deal with that, right? So it's definitely impacted my mental health between my family specifically, but also I see that, like I said, in my physician and my nursing colleagues, and as well as everyone else that works at the facility at times.
Thank you for being forthcoming about that. I want to encourage anyone, by the way, to send in questions if they have them, because we're going to keep going and taking your questions. I'm going to shift a little bit toward starting to talk, but feel free to bring up other questions about tools that our experts think we could be thinking about, or ways to think of the future of how to manage some of these issues, or even perhaps individual coping tools for all of you. So I have actually a couple of questions that relate to this, and then we'll start going around. But basically, we have a question from somebody who says, similarly in the UK, that staff are sleepwalking into an abyss, and that we need sort of a global approach of what do best practices look like for dealing with this, and how do we understand the cultural meaning of coping and mental health. And for many, it's more than just COVID. It's about the layers of racism and abuse and migration status and health risks. And we also have a question from a social worker who says they're working with families who are struggling with the, children and adolescents having regressive behavior in this setting. Not surprising. And how can we mitigate this when there's still so much uncertainty? And I think that applies to all of this. There's still so much uncertainty as to when this will all end. So I'm going to go to all three of you, but maybe I'll start with Tony so that he could address specifically in children, how to cope and deal with some of these things?
I think the central issue for children and for adults as well is control. In the context of an epidemic, pandemic, one loses control. What to do, when to open schools, when to close schools, when to go to work and risk exposure to office mates. In the context of government and health experts who don't know the answer to these questions, produces a climate of uncertainty and a lack of control. And I think that that is the most fundamental issue, is how does one exercise control in a situation that is so lacking in predictability and resources and that sort of thing.
Thank you. Jesse, can you comment on tools and forward-thinking policy ways we can be handling this?
Sure. So in the individual, which I hate to say is the first place to start, because I never like to tell people that they need to fix themselves. And especially in medicine, because they get really angry and think that I'm not acknowledging that the system is broken. I know the system is broken, and I would never tell people to fix themselves. But in order to survive in a broken system, you need to be able to survive. So here, when I talk about what you can do as an individual, I would say anxiety coping skills in the moment. So figure out what works for you. Don't fit other people's coping skills onto you. Like, lots of people think they fail at coping because all of these people on the TV talk about various coping skills, and then you go and try them and you hate them. Like, I hate mindfulness. It doesn't mean it doesn't work for a lot of people, because it does. And there's a lot of evidence that says it does. But if you hate it, you can hate it and you can go for a run. So figure out what works for you and do that. Second, have some self-compassion. We are very mean to ourselves, and we like to be mean to ourselves, particularly in medicine. So try to do that. So talk to yourself like you would a friend, or like you would when you were a kid. And the third thing I would say is actually give yourself some space to have feelings. So we actually never say, like, how am I doing? Because we're very focused on how other people are doing, including our friends and family and our children and our patients, obviously. So give yourself a little bit of time to say, like, how am I feeling? What is that? Can I name that? Okay and fine are not feelings, by the way. Exhaustion is also not a feeling. So all of that needs to be like something that you can do for yourself. And when you name it, then you can kind of like figure out a way to cope with it. Now, and when you move outside of yourself to the system, that means the system has to acknowledge it has a problem. So how do we do that? One, we have to say, hey, we've had a problem for a long time, and a lecture on burnout is not going to fix it. It wasn't going to fix it back then, and it is definitely not going to fix it now. So the first thing to do, I think, is give us money. So we need money to fix problems. That means a long-term investment in actually helping with the mental health care of the people that work for you. And that does not mean just throwing a little bit of money right now, because this is a long-term problem. Nobody that is affected by this is going to feel better when the pandemic is over, because when the pandemic is over, they will feel worse. Because when the pandemic is over, they're going to go, what was that? I wonder if I have feelings. And they're going to go, what was that like? Especially healthcare professionals who ignored it the whole time because they've just been running on adrenaline. And trauma has no timeline and might come out in 3 years. So listen, give money to this, invest in this, care about your healthcare professionals, because maybe they'll stay at their jobs. So put money into this. And also that might mean you're paying for their mental health care. That's a thing. That doesn't necessarily mean they get it on campus, because they might not. You might be paying for them to get it off campus. That's a thing. Then I would say, make your healthcare system more open to talking about feelings. That doesn't mean you have to disclose your entire mental health history. So a lot of people think that when we want people to feel more comfortable talking about emotions, that we want people to be like, hello, I'm Jesse. I have depression and I'm on this medication. That is not what we mean. That's helpful because we need some people to do that because it normalizes it in the culture, and it has like these key examples like celebrities doing that. It's helpful. But we need people to say in teams, in leadership, in deans, people who run hospitals, hey, Did you know that it's really hard to have kids at home and be a dean? It is hard. Did you know I haven't slept in a year? Like literally one line in an email, empathy, all of that. Having some awareness of that will make a huge difference, because having like hints of feelings in emails, having hints of feelings in how you talk can really change the culture, and it'll start to make it so feelings and like will be like more pervasive. And so that when people have actual problems, they'll go, oh, that leader mentioned it was hard for them. I bet I can say, I'm really struggling. I need help. I need to miss work because I can't get out of bed every day, and they're not going to judge me for it. So that's just a couple of things, but that's what I would say.
It's a hard change to make, because as many of us have spoken about, it's really baked into the medical culture to be stoic, and like stoic equals good and not stoic equals bad. And that's a real problem for mental health care. Before Matthew, I'm going to go to you next. Before I leave you, Jesse, for Black and Brown mental health professionals, which I know you've written a little about and raised some voices, it's a particularly difficult time. Can you just comment on that and sort of helping that community?
You're absolutely right. And they also tend to not get the same attention in the same way I was just talking about. I mean, I think if you can imagine what it's like to go into work every day as a healthcare professional and see the kind of things where you see the same patients every day that start to look like you, to be one of the few, like there are 3% Black psychiatrists. So if you're a 3% Black psychiatrist and people are seeking you out because they would like someone that looks like them, so they understand what racial trauma has been like this year, that means they want to talk about racial trauma. That means you have to be there to hold that and listen to that. But that also means you understand racial trauma because you are a Black person. And so you are basically experiencing a lot and holding a lot and hearing the same thing over and over and over, because a lot of people are seeking you out for that. But you don't want to turn those people away because you know that those people need you. And so it is really, really hard. And that's what I'm hearing from my friends. And, you know, I can't speak from that as that identity because I am very much a white person. And I know that. And I am so privileged to even have this conversation from this point and this perspective. But I think that as a white person too, in a place where there aren't a lot of providers of color, I also need to acknowledge that that is something that people want in their provider and sometimes can't get, right? And so I also need to be aware of those issues and as able to ask and listen to those issues as someone wants me to be, and acknowledge that they might not want to tell me them and they might wish they were talking to someone else. So I think that's also something that I try to do from my position, which is to say, like, I'm white and I get that I'm white, but I know that this is a really hard time for you. So tell me whatever you want to tell me and I will do my best to be here. And you do not need to educate me about this because you do that all day. And so I think that that's something you can do as a white provider in a place where there aren't a lot of Black providers. But yes, the emotional toll that it takes to do that as a Black provider when there aren't a lot of Black providers and people are specifically seeking you out to be the person to listen to that is, exhausting is a very minimalizing word for what that's been like for people, and they are really struggling.
Yeah. Matthew, I'm going to go to you to talk about tools or policy change or things you suggest in terms of better practices. But in addition, that question came in, maybe you could start with this. Do hospital systems and other employers really care about how their employees are feeling?
The easy answer to that is yes. I think they do care. I do think that they have the desire to care. Sometimes I'll admit it's difficult to feel that when you're in the trenches on that front line, right? To feel that that's what's being cared about, that you are the one being cared about and not just the dollars and cents component of healthcare, which is, you know, like Jesse had talked about, as part of that broken part of the system that we work and that we live in. But yeah, I would definitely say that they do care. but they have their own constraints as well, that they have to deal with. As far as resources and stuff like that are concerned, and I can talk a little bit obviously more about the nursing and more allied health kind of side of things, if you will. There are a lot of resources that are out there for individuals if they want to be able to take advantage of them. Not that these help everyone by any stretch of the imagination, but it's some things that can help us feel that we're not completely alone in this mess of healthcare that we are working with. Of course, the American Nurses Association, a member of that as well, has a COVID-19 resource center on their website. It has a lot of good tools, a lot of good information on there, not just educational information, but also information for working with and dealing with mental health and effective self-care type of tools. Sigma, or Sigma Theta Tau International, has a large component on their website of their Find Your Forward, which are resources for advocacy and for strength. And through some of the research that they've done and looked at, we know that 40 to 50% of nurses are experiencing some degree of burnout during this pandemic. And in many places, obviously, it's going to be a lot higher than that. And that COVID-19, has added additional layers of stress, as well as, and I even think even more of fatigue to our daily lives on the front lines and actually working with patients. So having what we call micro-learning, if you will, listening to individuals talk about different types of things, giving you different things that you can utilize to kind of help center yourself and find your way to be able to move forward in your day, as well as finding your way to be able to go to that next shift or to leave those patients that you've been working with all day and let the next shift take over. Those kinds of things are really something that does help from a mental health standpoint to kind of help center us a little more so that we can move forward.
Thank you. Tony, I wanted to give you a chance to also speak to, so we've been talking basically mostly about children and hospital staff and nurses and mental health professionals in this country. But we know this is a global, so worldwide problem. And we know these same communities are struggling in other places. But there are some differences here. One I know that you can speak to, it's basically what your new book is about, but or has a lot to do with it, that we're one of the only countries really to not exactly recognize children's rights as human rights in the same way. And the impact of that on children now in terms of the stressors they're facing with this pandemic. So I wondered if you could comment on that. And actually a question came in from an attendee too. Maybe you could, would this apply for children? Someone who is a social worker who leads a critical incident stress management peer support team in their healthcare system, and thoughts of the benefits of peer support teams and services, peers being helpful to peers.
Great. Thanks, Gail. I spent a long time, many years in the HIV pandemic as it played itself out in Tanzania. My research project evolved to focus on science education of children, that children received, as a way of moving them out of the position of being vulnerable or victims and being solvers or decision makers in their communities. And that would reflect the fact that they had a competence and a confidence in being ambassadors of the science of what was going on in communities that would mobilize their communities to see them as effective citizens and engaged, and help the whole community deal with how to control the epidemic of HIV, which during the first decade of this century was a huge catastrophe in Africa. It turns out that children as young as 10 and 12 could learn the microbiology of HIV and communicate that through drama and other techniques And that experience gave them a sense of control over the epidemic, that they weren't victims, that they were educated about it and could do something about it, and needed to develop a collective approach that involved their parents and teachers and in a multi-generational citizenship to stop the epidemic. They succeeded.
So
And
this is
we think that the same techniques that we used in HIV to give children control and voice and shared action with adults is something that can be done in this pandemic. That's why I'm so concerned about the fact that children's voices are not part of the solution so far.
so basically helping children to enact what we would call an intellectual defense. Intellectualizing and understanding the material and therefore being able to do things that are helpful in that setting is helpful for their mental health as well.
Right. And the way they're perceived by adults, that adults perceive them, have to change their perception of children from irrational and impulsive and unreliable to rational and observant and creative in solving problems.
And Jesse and Matthew, do you all have thoughts about the importance or usefulness of peer support for health professionals, for mental health professionals? Not something we've typically done.
Yeah, I can start with that one. I definitely think peer support is huge for us. I know specifically in my area of emergency nursing, with the Emergency Nurses Association, a lot of us that are involved in that particular organization, it does us good to be able to have the meetings that we do have, even though if they are Zoom type meetings, but at least to be able to get to see each other and talk to each other and know that we have those similar types of feelings, those similar types of experiences. And that's one of the families, quite literally, that we can lean on, to be able to have those kind of discussions that we can't really have with our true blood families, if you will, because they just don't get sometimes what we have to go through in the, quote unquote trenches, if you will. We just had a meeting yesterday at my particular state in Indiana, had our meeting. And it was so good to be able to see so many other people from around the state. And so many of them were saying, we just love seeing your faces, because we haven't had the chance to do that, within the past year. But just to be able to have that camaraderie, and also to be able to talk to each other about the same kinds of issues that they're seeing, same kind of things that I'm seeing, same kind of things that we're seeing in different parts of the US and even the world. Really to be able to have that kind of support, I think it means a lot to be able to have that.
Jesse, your thoughts on that?
Yeah, I think the hardest thing in this population period is selling the item. So basically, we have a lot of need, and sometimes people don't use what we make to help with it, right? So a lot of people during the pandemic, like a lot of hospital systems were like, the solution is to have just open, free support, like support groups. And a lot of people donated their time, including at my hospital, to just open Zoom and have it open to whenever people all over hospital systems wanted to come in and just talk, right? You didn't even have to say who you were and what your name was, any of that, just like talk, right? Same thing happened. A bunch of hospitals all over the country. Attendance was horrible, and including in hospitals all over the country. And when it happened for us, we were like, what is this? Is this a fluke? And so we called, and that's why I know it's the same thing around the country. And I think it's a question of like, what that cognitive dissonance part, which is like, how do you get somebody to go? It's not just that we know we have problems, because we're getting there to be able to say like, this is not just something that doesn't happen, that is only happening to patients, right? We know these numbers, people keep throwing them at us, we hear it. Now we're trying to associate the numbers with our feelings and trying to be able to say it out loud, but if we can't even barely get someone to say that out loud behind a door to me alone, it is very hard to then get them to say it in a group with a lot of people. The value of group support is immense in terms of validation, normalization, like hearing that they're like not alone. It's powerful. It is immense how important it is, but it's really hard to sell. It's hard to sell to college kids. I can barely get the college kids to go to groups, and they're like, why would I want to say that in front of them? They go to class with me. They're going to judge me, like whatever. But it's so, they would then feel like they're not alone. Like it's so powerful, but it's so hard to get them to do it. And I think that's the part that we need to figure out. And if we can figure out how to sell it, I love peer support. If someone could tell me how to get people to use it.
Well, actually, to relate to what some of you have brought up, well, we're talking about the within, but even for the taking care of others, one attendee notes that they're finding that therapeutic relationship has been massively changed with all this wearing of face masks, this loss of being able to see faces, whether it's, I think, this person's talking about the therapeutic relationship, but there's also peer-to-peer, you're working over patients, you cannot see anybody's face. There's all the social distancing. Can you all comment from your perspectives how that may have affected you? Anybody want to take that?
I can say from one that's wearing that mask, all the time, in the clinical setting specifically, it definitely impedes your interaction, not just with your patients, but definitely with each other, right? There have been times over this, the span of this pandemic, that we have been working with each other, been seeing each other for an entire day. But when we, get ready to leave or whatever, and as we're walking out, we see people, towards their cars and stuff like that, taking those masks off. It's like, I didn't even know you were here today, right? Because all you see is just that, right? It definitely does put a bit of distance, if you will, within that sphere of who you're working with and who you're dealing with. And I can only imagine, I do know and understand, of course, what it even does even more so for pediatrics and for children, period, when they're coming into some type of a healthcare environment. The fact that they're coming into that, seeing nothing but these masked people anyway, where their anxiety is already, probably through the roof as it is. And it's just even more exacerbating what they're having to go through.
Well, you guys have been tremendous. Thank you so much. We certainly crammed an awful lot into this hour, and I hope people found it helpful. There are resources that have been sent to you. So more information from each of our amazing panelists. Thank you so much for being with us, and I want to turn it back to Donna.
Oh, Gail, thank you so much for moderating this great discussion today, and for organizing this and bringing this this incredible panel together. I could have spent a lot more time listening. I wish I could be sitting in a room with all of you. It was a really meaningful conversation. I was really struck by your comment, Jesse, that trauma has no timeline and this will not go away post-pandemic. And so it's so important that these issues are elevated and they are front and center. And I really appreciate how Tony and Matthew, Jesse, you all brought really concrete solutions, not necessarily easy or simple, but thinking about how to repair the systems for the long term. It's just so valuable. And in thinking about peer support, I hope you'll come back. I hope there'll be more opportunities for us to continue these conversations. And for panelists who are listening, share this video. We will put it out on our website and we'll put it on social media. Think about those healthcare workers who will really relate to what Matthew talked about what his experience is like, and to family members who want to better understand what the experiences are of their frontline loved ones. So thank you so very, very much for your time, your incredible words of wisdom, your solidarity, your activism. And Gail, thank you once again for moderating this discussion. It was absolutely fantastic.
Thank you.
Thanks for having us.
Thank you very much.